online at the moment and joined us from all over the world. We have everyone, people from all over today. So Femi Vadakan from PHRI will be doing our study update today, as most of the senior management from PHRI are currently traveling. So over to Femi. Femi is a shame. She is still she's on leave and she's in India. So she agreed to help us out today. She'll be doing the study update.
Thank you, Elsa. Hello, everyone. Because I'm calling from India and my internet connectivity is, I'm not quite sure how it is. So hopefully it will go okay. And if there's any issues, please bear with me. So maybe I'll go off the camera just so that it is better. So I'll go off camera for now, and then I'll start the Revive update. Okay. So thank you so much for joining with us this afternoon for this exciting webinar. I would like to extend a warm welcome to all of you. As we usually do in our Revive webinars, since not everyone joining today is directly involved in the Revive trial, we will start with a brief introduction to the Revive trial, followed by an update on our progress. We'll start with the slide. Okay. The Revive trial is a collaborative effort led by the Population Health Research Institute in Canada and the University of Cape Town in South Africa with funding from the Gates Foundation. This pragmatic, multi-center, double-blinded, placebo-controlled randomized trial aims to answer an important question. For patients with advanced HIV and a CD4 count of less than or equal to 100 who are either starting or reinitiating antiretroviral therapy after an interruption, does a 4-week treatment with azithromycin at 250 milligrams once daily compared to placebo reduce mortality at 24 weeks of follow-up? We hypothesize that azithromycin prophylaxis against common bacterial infections will improve survival in these patients when added to the standard of care. To give you a quick overview, the trial enrolls adult patients over 18 years of age with a CD4 count of less than or equal to 100 who are not currently experiencing an acute illness. These patients are randomized to receive either placebo or azithromycin and are followed for 6 months for the primary outcomes with additional follow-up to 12 months. In terms of our geographical reach, we plan to enroll 8,000 participants across 13 countries. As of now, 11 of these countries are activated. They are highlighted in green on the map, and Ethiopia is our latest addition. The remaining countries, Kenya and Cameroon, are still in the process of activation. We have a planned 64 sites across these countries, and currently 53 sites are active and recruiting participants. Can we move on to the next slide? We aim to recruit 8,000 participants in total, and as of September 24th, we have enrolled 3,549 participants with 339 new enrollments in the last month alone. In the 10th column, which is the total participants randomized, you can see the number of participants that have been enrolled in each country cumulatively over the time period. This is a major achievement to date in terms of keeping up with our target. The next slide summarizes that graphically. You can see that the target is to end enrollment by November 2027. And to meet that target, we need to stick to that blue line. Our goal is to enroll over 200 participants per month to stay on track with our projected timeline. The purple line represents the cumulative achieved enrollment as of August 2025. Our progress to date is excellent, with cumulative enrollment reflecting contributions from all participating countries. At the current rate, we should reach 50% of the target before the end of this year. A big thanks to all the sites for their dedication and hard work. I think I will now hand it back to Elsa.
Thank you very much, Femi. We really appreciate you joining. Enjoy the last bit of your holiday. We will let you off the hook now.
Thank you. Thank you.
Good. So this is my honor today to introduce to you our speaker of the day. And she is Professor Christine Sekaggya. She's an internal medicine physician at Mulago National Referral Hospital, also a senior research scientist at the Infectious Diseases Institute, and a senior lecturer at the Department of Internal Medicine at Makerere University in Uganda. Prof. Christine's primary research interests are in HIV and tuberculosis, with extensive leadership in clinical trials on anti-TB, TB treatment shortening, and TB preventative therapy. She contributes globally as a member of the WHO Scientific Development Group for TB Diagnostics and the Technical Advisory Group on TB drug dosing, and nationally through her role in developing Uganda's clinical, essential medicines and COVID-19 guidelines. We are delighted to have Professor Christine with us today and look forward to her sharing her expertise. Over to you, Prof. Christine.
Sorry, wrong button. Thank you very much for the kind introduction, Elsa. I'm going to share my slides in a second. Just tell me when you can see my slides.
We can see them now.
Okay.
This is your screen that we're seeing.
Okay. Okay. That is not what I meant to share. So sorry, let me just look for the correct slides. Can you see the right slides now?
Yes, we can.
Okay, don't know if it's in slide share mode.
It's not yet. Yeah, that is now, yeah.
Okay. Okay. Just need to hide these panels. Okay, so good afternoon, everybody. I'm happy to be able to present something to your very highly esteemed group this afternoon. Thank you for inviting me to present, and it's nice to see some familiar names on the screen as well. I'm going to just take off my video for now so that my internet doesn't become funny. So I'm going to present something about considerations for high-dose rifampicin in optimizing treatment for drug-sensitive pulmonary TB. And as introduced, I'm Christine Sekaggya, wheelchair from Infectious Diseases Institute, Makerere, and from Mulago National Referral Hospital. So just as a background, majority of our patients are recovering successfully from TB treatment. A few of them will go ahead, however, to have treatment failure and relapse. From our Ugandan data, our failure rate is just less than 5%. And from a study actually done by our NTP current chair, a relapse at 2 years of follow-up was found to be about 10%. And the majority of those were relapses, and 18% were found to 18 were reinfections. So the larger proportion of people who were found to have TB again at 2 years were actually relapses. So our relapse rate is a little higher than our failure rate, but this is a very old study, so I'm thinking things should be a little better now. We have this pool of people circulating, as we know, with latent TB. That was constantly contributes to the pool of people who have active disease. So from our hospital here in Mulago, when they did a survey for latent TB using IGRA, we found that about 50% of the healthcare workers, ranging from nurses to doctors, pharmacy staff, and other hospital staff had latent TB, so about 50%. But I tell you that none of them went to receive TB preventive therapy. So effective treatment is not only needed for active disease, but it's also needed for latent TB disease. And as we used to learn in pharmacology, we need to always have the right drug for the right patient, the right dose, and the right timing. So when it comes to TB, what I would say is, okay, yes, we need the right drug. We need to be treating the right population of people. Whether you're treating, we need to know that you have the right timing of the disease, because as we know now that TB is a spectrum. We need to know if we're treating latent disease or active disease. So the right timing is important, because it will dictate what kind of drug we're actually using and the right dose. Now, while all these might be correct, we also need to make sure that the drug is actually getting to the place where we need it to act. So previous considerations of rifampicin dosing were mostly based on cost and safety, starting from a dose of about 600 milligrams. At that time, there was very little PK and PK/PD data. So that was the basis of where the rifampicin dosing came from. And as we've now gone on to learn more about TB drugs, we know that there are two major phases at which the drugs work. We have that first phase where the bacteria is multiplying very fast, high bacillary load in many of the patients that we see here. And if you see that first alpha slope, that is the killing of these rapidly replicating bacteria that will take up the drug very avidly. And that's isoniazid and rifampicin, which have been associated with early bactericidal activity. Then we have this group of bacteria that kind of sleep and then wake up and sleep and wake up, and where we have largely rifampicin and parazinamide coming in the sterilization phase. And then the ones that are actually asleep, we have that yellow group, the yellow B2 group, which are killed mostly by rifampicin in the sterilizing phase. Well, ethambutol basically hangs around to prevent resistance and has a bacteriostatic effect. So our drugs are basically working in one of these or more than one of these phases. And we've really capitalized on the early bactericidal drugs, isoniazid rifampicin, through either increasing the dose, and these are responsible for that rapid clearance of bacteria that we see in the first 2 weeks in a large proportion of patients. So we were talking about drug penetration. So you have a drug and we don't usually focus so much on where it's going. So we know that a lot of our pharmacokinetic studies have been focused on plasma concentrations. And I know many people are currently working on concentrations in other target organs and target sites, including the CSF. But for the most part, we've been working with drug concentrations within plasma. But when we know what we know about this, I love this diagram, which just tells us about the site of action. So we know that caseous granuloma, full of pus, necrotic tissue, can be hard to penetrate for many antibiotics or antimicrobial agents. So from this work, we see that drugs like parazinamide and isoniazid, metabolite acetyl isoniazid, actually seem to do quite well in this area. And this is really dependent on the unbound portion that is really the active portion. And we can see that a lot of it is appearing within the lesion. Unlike the other drugs, moxi, rifampicin, clofazimine, bedaquiline, that have more binding to the caseous material, and therefore is less accessible to in the lesion to actually kill the bacteria. So this is something to think about when we are, one, doing our pharmacokinetics work and looking at new drugs as well. Concentration at target sites is very key. Now, when we talk about concentration at target sites, we're also talking about we need to have a reference range. So our concentrations, we're giving the drug, but what targets should we actually be achieving? The frequently used targets that we have been mostly from healthy volunteers, but I'll talk about rifampicin in particular since it's the focus of this discussion. Otherwise, we can go on and on. Rifampicin, we usually use a reference, a range of 8 to 24 for Cmax. The AUCs have been less clear. More recently, the other targets have been investigated by different authors and still ongoing to identify clear targets for AUC especially. Now, previous work that we have done in about just less than 300 people who are living with HIV, and we just, in this diagram, in this figure, we plotted different time points, week 2, week 8, week 24, looking at exposure, both AUC, which is the upper figure, and Cmax, which is the lower figure. Just comparing the target attainment in those who are cured and those who are not cured. And we used 2 different targets. This is old data of several years ago, but it's just quite interesting to see if we look at isoniazid, whether the people who are cured and not cured all had concentrations above, let's say, if we use the AUC target of pasipanodia, they were all above that target. However, we can see that the Cmax targets, both for chacpilocin, which is what we commonly refer to for Cmax, and the ones that were suggested by pasipanodia, a large proportion of people had concentrations below these targets, but this is regardless of whether they were cured or not. So there's that debate about the actual meaning of these targets and correlation of concentration treatment outcomes. So in this same study, among people living with HIV who are newly diagnosed with drug-sensitive TB and starting treatment recently and we're just starting TB treatment, we measured these drug concentrations again at week 2, 8, and 24. And you can see in the Fox plot on the left where we have rifampicin concentrations in gray, and the white are the isoniazid. The Fox plot in white is isoniazid. And if you look at the targets, the upper line is the target for rifampicin and the lower one is the one for isoniazid. So we found that 70 to 80% of our participants actually had Cmaxes that were below the stated targets. These are referring to the chacpilocin targets of 8 to 24. So these had the value below 8 milligrams per deciliter, so micrograms per mil in this case. So it's obvious that a large proportion of our patients have both isoniazid below the target. Think for pyrazinamide and ethambutol, they were much less, like 20% or less for this particular population. And when we correlated it with, in particular, notes that we're now correlating it with time to sputum conversion, we found that having drug concentrations of 1 or more drug below the target, if one or more drugs were below the target, patient was more likely to not convert. So basically having both drugs above the target increased your chance of converting culture conversion faster. However, when we look at things that could predict these drug concentrations, 2 things that stood out were the body weight and also formulation. So we went ahead with some people in your group, Paolo Denti and his PK modeling team, to look to model these drug concentrations and to predict what they would be if we actually increase the dose. So from this work done several years ago again, we can see that we divided the patients' population according to their weight bands, and we found that those who had the lower weight bands, who are in the lower weight category, you can see 30 to 39, and others have also found this as well, had significantly lower concentrations than those in the higher weight band. So for this particular paper, we just predicted that what if you just added 1 FDC, one fixed dose pill on top of the standard that they were getting. And we can see that for some, adding that top up for AUCs actually increased the exposures. So this is just some of the modeling work and might be a reflection of the discussions that are ongoing about adjusting the dose of these drugs, especially rifampicin. But when it was this, there were 2 systematic reviews who were correlating concentrate there. I think they're probably more than that now, but I just want to highlight two systematic reviews, one selfishly because we were part of it, and then another because I know some of the people who are part of it, so forgive my biased presentation. But in these systematic reviews where they're correlating concentrations and treatment outcome, we can see that the evidence for correlation of exposure and actual treatment outcome based on cure as opposed to sputum conversion is quite limited. We can see that from the systematic review on the left, the risk of poor outcome with low rifampicin concentration was not statistically significant, although it seemed the risk ratio was 1.49, but as you can see, the confidence interval actually crosses 1. And the other systematic review, which I think is done by people on this call here, also showed there's no evidence of increased efficacy of higher doses of rifampicin. Note that these trials both, I think the one on the right had about 19 studies, and the meta-analysis with some of our data had about 13 studies, and the doses explored were variable. I think most of them were up to 20 milligrams, and not many studies that went up to 35 milligrams per kilo. But this basically just shows that from the data we have, correlating with concrete outcome like cure it doesn't seem to correlate very well with drug concentrations. So now we based on the fact that concentrations have been low, had some evidence that it correlates with time to sputum conversion, maybe not with concrete outcomes like cure and relapse. Many groups have been evaluating high-dose rifampicin, and again highlighting just a few of the studies that have happened so far. We have the Rislami, Rob Arnott's and his group who evaluated 10 to 13 milligrams per kilo. And of course, they find higher exposures when you give high doses of rifampicin. So there's that there's that increase in exposure of rifampicin as you increase the dose. And again, the high-RIB study where they compared 20 milligrams per kilo, 15 and 10 milligrams, the standard of care, with a primary outcome of the AUC between 0 and 24 hours after 14 days, where you think you have steady state, and looking at how many people, looking at achievement of a target again of 8, they found that the higher dose, as you increase the dose, the exposures, the AUCs actually also increased. Then later on, we have the Panacea group that looked further at 35 milligrams per kilo in addition to the 10 and 20 milligrams per kilo, and found it to be safe. And not only to be safe, but it's actually 35 milligrams per kilo decreased the time to culture conversion, similar to other studies that showed that higher doses of rifampicin were associated with decreased time to culture conversion. Now we know that time to culture conversion, or the month 2 culture positivity rate, might not be the best marker of overall cure, predictor of cure. However, this marker is what's frequently used in trials, testing new regimens. So, it's what we have, and it's proved to be quite good, although it doesn't correlate with the overall end outcome of cure or relapse. So reflecting the same in drugs related to TB meningitis, the higher doses of rifampicin when given orally were associated with higher exposures, both AUC in plasma and in CSF as well, and it was also found to be safe in these studies. So the studies of high-dose rifampicin, multiple, I've highlighted just a few, and generally show some effect on time to sputum conversion, and and have proven to be safe as well. So for safety studies, I just highlight the Referral study, which was in a population that was that was HIV negative, where there was no increased risk of toxicity with 20 milligrams per kilo compared to 10. And then another study done here in Uganda, the SafeRiv trial, with people living with HIV. All of the patients were living with HIV and had TB. And there was also no increased risk of toxicity with 35 milligrams per kilo compared to 10. However, the safety assessments that we frequently use, we really look at safety, but sometimes we also need to look at things like tolerability. And we see that for some patients who have higher dose, we might have an increased reporting of GI effects like nausea and vomiting, but not many of that. Those are frequently not captured in our trials that are really looking at things like liver toxicity or the overt more severe toxicities. So we frequently focus on those safety signals, but don't really look at the tolerability for patients, which is something that also needs to be considered because that will affect the way people actually take their drugs or not. So we looked at drug interaction with dolutegravir. So we know that rifampicin does decrease the dose of dolutegravir, and we looked at it at 35 milligrams per kilo in the SafeRiv trial, and found that yes, it did significantly decrease dolutegravir concentrations when given at a dose of 35 milligrams per kilo. However, all our patients did remain biologically suppressed despite the low DTG concentrations, and that we know is DTG is quite forgiving in its action. So this is some of the data we have. We plotted both those who are below the limit of quantification and those who were excluding data, those who are below the limit of quantification. And basically, this is a sensitivity analysis and produced the same thing. And thanks to, again, Paolo and his team who helped us with this modeling. So going back to the timeline of high-dose rifampicin studies, we move on to how exactly we can use the high-dose rifampicin in shortening TB treatment. And then we had the Referral trial, where we had 4 months regimen. 4-month regimen was given 1,200 milligrams of rifampicin and 1,800 milligrams. That study failed to meet the non-inferiority criteria compared to standard. However, we know the study 31 that led to a change in our treatment guidelines and introduced a new regimen recommended by WHO that included rifampicin and moxifloxacin that showed non-inferiority of this regimen to our current guidelines, and which was a really breakthrough for drug-sensitive TB. I think this is it's been several years before a new regimen came up. So, however, we know that the uptake of this regimen has been quite limited for several reasons in different countries. One could name that we don't have fixed dose, the FDC's fixed drug combinations for this combination available. Also, the cost of rifampicin is quite high, and also WHO recommending that probably you need some resistance testing before you use moxifloxacin immediately. So this regimen hasn't been widely taken up just as yet. Moving on in still looking at TB treatment shortening, we had the Truncate TB study, which was quite an interesting study that took place in Africa and Asia. It had about 18 sites. It looked at 4 boosted regimens, so that adaptive trial design, but only 2 of the regimens went on till the end. Up to the end of the study, all the patients were largely the HIV negative patients. So the 2 arms that went up to the end of the trial, when compared to standard of care, so the 2 arms were the bedaquiline and linezolid arm, and then the rifampicin linezolid arm. and rifampicin was given at a high dose at 20 milligrams per kilo for most of the patients. So this study actually did show that this strategy, which I'll just talk about later, could work. And there was non-inferiority, but only with the bedaquiline linezolid arm. So the high-dose rifampicin 20 linezolid arm was not non-inferior to standard of care. So the non-inferiority was only met by this one bedaquiline linezolid arm, which is quite interesting, and I'll just delve into that a little more after this. So study 31, as I've highlighted, was introduced into the guidelines. We were all excited, thought that now we'll have a 4-month treatment regimen, but currently no one has been, I'm not sure of any group or country that has been able to implement it, but I think this gives us hope that using the old regimen, modification of the old regimen with addition of additional drugs can probably lead to use of achievement of this shorter treatment duration. So if I delve into the truncate strategy, again, this is a biased presentation because we were part of this trial. The 6-month standard regimen was compared to this 2-month boosted regimen. And what would happen is the patient is treated for 2 months and then undergoes monitoring for symptoms and smears. And the treatment could be extended if the clinician felt that they needed to be treated for longer. And then those who, the large majority you expect to be cured, but then those who are relapsed were then started on the standard 6 months treatment. And so this was basically the strategy. And the results actually did show, as I said, that the bedaquiline linezolid arm did meet the criteria of non-inferiority for this trial. But it also just demonstrated that this strategy is positive, but with a few caveats. Another group led by Rada looked at pooled level analysis, looking at, I think there were about 3 trials that were, data was pulled together to say that, okay, if we're to give a shorter treatment regimen, basing on the 4-month regimen, who are the people who are likely to benefit, or who are the more people who are likely to be at risk of poor outcomes? And they found that this 4-month regimen is probably beneficial for the people with minimal disease, and they characterize that as having no cavities and a lower smear grade. They also found predictors of poor outcomes for the 4-month regimen as people who are HIV positive, the older age males, and people who are not adherent to the treatment, less than 90% of the doses. So these are things that we can probably use when we are looking at considering treatment shortening. So in practical life, we hope that one day we'll be able to sit with our patients and say that based on the fact that you do not have HIV, you're younger, and you have a smear grade 1, you can qualify for a shorter TB treatment, for shorter treatment regimen. So these are based on a lot of clinical biomarkers, but we hope that they could be one microbiological marker. The frequently used biological marker for treatment response is that month 2 culture positivity. However, it's not the best biomarker, and cultures are quite expensive for low middle income countries like Uganda. So exploring best biomarkers that can say that based on this one biomarker, you can then be able to use a shorter regimen would be the ideal. So some considerations to think about. Rifampicin exposures are evidently low in many of our populations, and in some people more than others. For example, clearly demonstrated in people living with HIV. So adherence, of course, to a very long treatment is still an issue, and we therefore need to have shorter regimens that can be easily taken up. And so in my opinion, dose adjustment of these drugs, and I've not even gone into isoniazid with its complexities of NAT2 genotyping, is inevitable. But then how do we safely increase these rifampicin doses? One could think, can you just use the fixed drug combinations that we're currently using and top up, or do we get separate rifampicin doses and top up, or do we get new FDCs, which of course will be the ideal, but that would take time and money. And then there are also arguments about whether to use flat dosing versus weight-based dosing, which one is practical, which one achieves target concentrations better and will improve outcomes better than the other. And then what dose is sufficient? Because safety is key, but also tolerability to a patient is very important. And we need to start measuring tolerability at the patient level for a patient even more than we do now in clinical trials when we're looking at newer drugs. And then for when we actually modify current regimens, that which seems to be the way to go. It might be an issue like what in study 31 is to modify the current regimen by changing the accompanying drugs. But this has to be based, of course, on the resistance profile, the place that is using the drug, so that we can prevent selection of resistant strains to possibly new good regimens. And then, of course, safety regimen would be key. And frequently in countries like ours, where we don't routinely measure, say, liver function or full blood count at every visit, and until the patient presents with symptoms that warrant it. So while we think about modifying our current regimens, we also need to strengthen health systems. These health systems need to be strong enough to be able to test these new regimens in a routine setting. When we talk about therapeutic drug monitoring, this is an exciting thing, which we hope that would be doing in several countries, because one size doesn't fit all. So how can we do this therapeutic drug monitoring safely? Right now, we have a TDM study for isoniazid, where we're doing therapeutic pharmacogenomic guided dosing for isoniazid based on the NAT2 genotype, sorry. But is this feasible? Or can there be centers of excellence where this can be focused so that difficult patients or patients who are more challenging can be managed in centers of excellence? But so this is the ideal again, and it's very possible in very many places, but needs to be thought about in a cost-effective way. For example, can we have a point of care drug concentration? You have a point of care machine that can measure drug concentrations, and then you can quickly feedback and escalate the dose in a manner that we need to also agree on. But these are things that are still in the making, and I know there are other groups that are working on point of care techniques that can help in therapeutic drug monitoring. So I'm going to end my my presentation there with a thank you again for inviting me. And I put the map of Africa because I don't take it for granted that everybody knows where Uganda is. And just to show some of the community initiatives that we're doing to screen for TB within the community in the rural areas, and in affiliation with National Referral Hospital where I'm also based. So thank you very much. And I'm happy to discuss further with the team, with the group.
Thank you, Professor Christine. This was really a very insightful and informative presentation on something that is really important to, I think, everyone across Africa. So yeah, can we open the floor for everyone who has got a question to just raise their hands, and then we will address them.
Since these are all people working the TB space, I expect their comments and discussion points, since everyone will know the answers to the questions.
Is there anyone with any questions? Are we going to let Professor Christine off this easily? Stella, you can proceed with your question.
Yeah, thank you very much, Elsa and Christine. Sorry I joined late, but then I have captured some of the presentation which Christine has made. Very nice presentation. So my question is on the isoniazid TDM. I'm keen to learn more on this. Are you also considering the individuals who are rapid or slow intermediate accelerators in your digesting pedology? Can you explain a little bit more? How do you try to deploy this? Thank you.
Thanks for the question, Stella. Nice to see you on this forum. So yes, so for this study, we are doing genotyping for our patients ahead of time. Sorry, there's a loud truck in my background. We're doing genotyping and classifying them and allocating according to genotype status. The slow and intermediate are being classified together, and then the fast being given the higher dose, but the slow and intermediate being classified together as getting the standard dose. But what we also did for a few of the intermediates is give them the higher dose, and we'll see what the data is for that, just to see what the effect is. But yes, we're dosing them according to the genotypic, not phenotypic, genotypic status. So it's quite a complex study because we had to do the genotyping first, and it takes a few days, and then within 2 weeks of starting treatment, then we escalate the dose if they needed to.
Okay. Additional follow-up question on that. Do you also test the drug levels after doing that?
Yes. So it's within about 2 weeks of that where we're testing the dose again to see, but we don't do it if it's suboptimal. We don't do it again. We just test the dose once. But I'll also tell you that we're doing the same in another study for rifampicin, but without the genotyping. We are doing therapeutic drug monitoring by just checking the dose within 2 weeks of initiating treatment, adjusting the dose for those based on AUC and Cmax, and then measuring again after 2 weeks, and then we adjust again if need be. So we're doing one for isoniazid that's based on genotyping, and one on rifampicin that's not based on genotyping, that is just based on concentrations within the first 2 weeks or at 2 weeks.
Thank you. It's clear now.
Any other questions from the floor? With Prof. Christine's permission, we will add the recording of this presentation onto the Revive website, and we can also share her slides, which she'd be fine in sharing them with us. Then we can share it with you if you would love to have them.
Happy to share the slides and the recording as well. I'm happy to have it on the
Thank you.
website. Thank you.
Thank you very much. Thank you, everyone, and thanks a lot for joining. This was our third last Revive seminar for the year. We will share the last two, which is in November, with you shortly, and also the invitations. Thanks for joining, and may you all have a very good day.